Okay, thank you very much for inviting me as the token physiotherapist to present. My focus is really going to talk about on a smaller level related to patients that I would typically see in the clinics that we run. So thank you for my colleagues who've spoken about the larger picture, but when you've actually got a patient in front of you, you meet some of the individual challenges, and I think it's very easy to think big picture, when in fact, when we've got that patient in front of us, it's big to them. So I'm going to take a slightly smaller view. So just giving you an idea, some of you will have heard people come to your clinics and say, I'm doing physio, or airway clearance techniques. And so what I wanted to do was just to introduce you briefly to some of the techniques that people might come and say that they're doing under the big umbrella of horrible chest physio. And kind of bring you up to date with some of the evidence that's there. And I will kind of have the disclaimer and hand on my heart to say in physiotherapy, our world is not kind of funded with huge amounts of significant randomized controlled trials, as is evident in other areas. So I'll put that disclaimer on the table first of all. However, in bronchiectasis, it's, as Conroy alluded to, it's a huge growing space. So I have included a slide of some of the work that I'm involved with, either directly or indirectly, through either the clinic or also my work at AUT. So going back to, again, trying to keep to that focus of Australia and New Zealand, because we're very good at importing other people's perspectives. It's nice to actually generate our own. And this was a piece of work that looked at suppurative lung conditions, including bronchiectasis. And what you find is that some of the key features recommended physiotherapy, at least to a referral or advice from a respiratory physiotherapist. It also looked at for people who were deconditioned, actually referring to physical or activity programs such as pulmonary rehab. And within the COPD space, pulmonary rehab as a program of education and exercise is actually now very, very well recognized as the gold standard. And we have a speaker tomorrow presenting on the Australia and New Zealand guidelines. We also need to recognize that bronchiectasis, as we've heard today, actually spans the whole continuum of age. And bearing in mind with youth, we could have people with very severe lung problems who are 15, 16. So I work within the predominantly the 15 plus age space. Taken literally, snapshotted from the 2017 October publication of physiotherapy management. The focus of the bigger umbrella is chest physiotherapy. In relation to mucus production, or rather mucus clearance, exercise intolerance, and also respiratory muscle weakness. So this is the bigger picture, and I'm going to go through just some of the key ones, but I'm really going to focus on the red ones, which are more commonly used within New Zealand. So we have the typical postural drainage, which is everybody will most probably recognize and remember and dread. We've also got typical techniques like the active cycler breathing, so it's abbreviated here as ACBT, also coughing and huffing. So originally designed more in the UK, it's very, very well established. But if you ask any person, including youth, who are totally honest, most and all of the time, they will tell you it's as boring as hell. So trying to market that is actually really challenging. So it's no surprise that a lot of our techniques now, particularly in Australasia, are equipment or device-based. So we have PEP, which is positive expiratory pressure. I'll show pictures in a moment. Or oscillatory PEP, called the a cappella, which is the most frequently used one I've come across in New Zealand. Exercise, I think the benefits are without speaking, and I don't need to talk to them. It's really about access. And inspiratory muscle training and AD, standing for autogenic drainage, they are available, but maybe not as readily available as the other techniques. So thankfully, we have moved away from postural drainage. This was actually in the 50s, so, you know, still of our era on genre. But thankfully, we have moved away from postural drainage. I think if this gentleman didn't develop reflux, I think he would. He's obviously on very high levels of Losec. We've even kind of moved away from the head tip position because of that association with reflux. and more towards more selective positioning and drainage of particular lobes. And this is where that link with the HRCTs, HRCTs is really useful. We can identify and be a little bit more selective. Now, that's not to say that people will do it, but we can certainly identify what is the best treatment. So traditionally, as I mentioned, the combination of the active cycle of breathing, and each of the techniques has physiological kind of underpinnings to support its use. So the active cycle of breathing is a cycle, as it says, of breathing, which incorporates kind of principles of collateral ventilation, interdependence of the alveoli, and equal pressure point movement to encourage better movement of secretions from distal to proximal airways. We've got PEP, positive expiratory pressure techniques. And again, these are the most commonly marketed ones that I've come across, even in talking with colleagues around the country. So we have the a cappella, which is the green device, which includes an oscillation. So that's thought to create a vibration, which will again enhance airway clearance. The TheraPep, which is the blue device. And I just want you to hold on to the thought that when I'm working with people, often I will look at what their learning style is. If they're a visual learner, they're often much better with a TheraPep, where they can actually see how it works, as opposed to people who are quite insightful and in the space of their own bodies, and they can be aware of what the oscillation can feel like on their lungs. And then there's the high-frequency oscillation vest. Now, just bear in mind, the active cycle of breathing and postural drainage is free, but boring. The a cappella is about $80. The a cappella is about $120 to $140, depends whether you buy in bulk. The TheraPep, about $80, and about $10,000 for the vest. So bear in mind our budgets, and bear in mind that there's also differences across different countries, but people are moving a lot more. In Ireland, for example, autogenic drainage is more commonly used. So this is drawing from their CF register, which again will hold benefit when we have that bronchiectasis register set up. In the States, adults with cystic fibrosis, 37% of them use the oscillating vest at $10,000 a pop, whereas 1% in the UK use it. In New Zealand, in the CF community, 46% again use exercise as a primary form of airway clearance. And without drawing you too much detail, it's just to show that really, to me, something is better than nothing. And it's about how we engage people to do something that ultimately will improve the mechanics of their clearance of secretions. So PEP, for example, this was a Cochrane review. Again, small number of studies, small number of participants relative to other research that we've heard today. But essentially, they've all got equity in terms of clearance. Again, very small study, but what I wanted to show from this was, in fact, that patients preferred the a cappella. And this is where sometimes our budgets and sometimes our traditional kind of practice means that we don't deviate a little bit. If people prefer it, they're more likely to use it. However, unfortunately, in this study, they didn't show long-term follow-up. But again, one of the benefits of the register might be to see what do people do at different touch points in the trajectory of their disease. This was presented by Laura, a colleague of mine, now working at Middlemore, presented some data at the Second World Bronchiectasis Congress. And really what I want you to take away from this slide is that people over the age of 5 traditionally were issued with a PEP device. What's also quite interesting is when about at least over 20 people who have transitioned from Starship to Counties adult services, funny enough, most of them haven't brought them with them, and they haven't used them. And in fact, some of them don't even know where they are. So again, it suggests that there's different time points, different touch points that maybe we need to revisit and look at how does physio best fit within their lives. Again, drawing from the CF literature, and this is where I hope the bronchiectasis literature will bolster up in due course. But again, looking at some of the other techniques undertaken in the UK, And what I want you to pull from this slide is the fact that a lot of males rather than females actually undertook exercise as a primary form of airway clearance, which is fine if you've got mild disease, as in an FEV1 greater than 70%. But if you're relying on this as your own or primary form of airway clearance, it can be quite challenging, especially if we look at physical activity in the wider space of New Zealand, where actually most people are failing to meet the recommended 150 minutes of exercise, of moderate exercise per week. So I would kind of put to you that maybe this level of physical activity is still insufficient. Within bronchiectasis and pulmonary rehab, again, we'll hear about pulmonary rehab tomorrow, but some evidence to show that there is benefit, both clinically significant walk distances and how that also translates into quality of life. On the downside is, and this hopefully will be an updated study soon, is the uptake of pulmonary rehab in New Zealand. Very few people were actually offered it. Less than 5% of people with COPD were offered pulmonary rehab. Now, I appreciate this is an 09 study, but at the same time, if we have a gold standard, why aren't people engaging in that program? And that's something that we need to look at, especially when it's held up and flagged up as the gold standard. And interestingly, again, the focus is on physical activity with children, but not formal exercise programs, the equivalent of pulmonary rehab in a much younger population. I think because part of my other role is working with people who have obesity and heart failure, the space that we're in about sedentary behavior is growing. We put a lot of effort and time and focus into activity, but in fact now there's a growing trend at looking at inactivity. And again, how can we engage people? If we think of our schools, how many children again fail to meet aerobic thresholds of exercise during playtime, play at the weekend, and even during formal exercise programs within the curriculum. And this is taking on a flavour in terms of chronic disease. People are now looking at the effect of sedentary behaviour. If you think of youth and how much screen time they have, again, it's not exactly the most active, but a slide later on will show how we can maybe use that as a form of engagement. We know that people will vote with their feet by not attending our clinics. We know that people will come directly to hospital and reroute back into our clinics again. When I first was involved in bronchiectasis, the average length of stay was about 5.2 days. When I last looked at it a year or so ago, it's 3.9 days. So what hope do we have at eliciting behaviour change? Not necessarily treatment, but behaviour change in order to engage with taking a tablet, taking an antibiotic, finishing their courses, undertaking airway clearance techniques. People vote with their feet. There's also a lovely phenomenon called appointment fatigue, where people get multiple appointments, even from the same teams, on different days. And we forget that the priorities and barriers that people have are not just about health. They've got a whole lives of which their health sits into that. Hot off the press, this is one of my colleagues from Middlemore doing her Master of Public Health, looking at barriers to access for children. So this is parents of children who are being interviewed. Again, we forget that people work, they have to take time off work. Can we give them an 8:30 appointment when they're on the way to work, but they've got 3 other children that still need to be dropped off at school? We forget that people manage things. So if in this scenario where the husband is earning more, he's the main carer, so the wife gets on with things, but has to juggle so many other factors. Some of the barriers to airway clearance, apart from, can I just say, it's boring. Don't let anybody ever try and say it's anything other than that most of the time. But people forget that there's actually a real social stigma to coughing. Job satisfaction to me, but to other people, social stigma. So again, expectorating sputum, coughing, is really, really inhibitory. Another factor, stress incontinence. So Price Prickard looked at a small consecutive cohort of females attending an asthma and bronchiectasis clinic, and over 48%, small number, but 48% of people in that mid-age range had stress incontinence, deemed by urinary leakage at least once per week. I reproduced the study looking at 75 consecutive females attending my clinic, irrespective of age, but they did vary from 17 to about 83. 68%, irrespective of age, number of children, where they were in their hormonal cycle, 68% of people, of women, had urinary stress incontinence. And more importantly, there was a high number who had USI on spirometry techniques, the techniques that we use to guide some medicines and eligibility, and also airway clearance. Harry Paparizis, again, he's a psychologist sitting in that sedentary space. Again, he says, you know, exercise isn't enjoyable. If you haven't been brought up with it, if your parents don't exercise, if there's that kind of philosophy in the family, it's very hard to engage with that. People don't want to make time. They're busy. So perhaps it's time to rethink our own thinking about how we work with people. We know that the evidence is out there. We've got the 2017 best practice or kind of ERS statement. Hopefully we've got clinical expertise. So everybody here has got a vested interest in some kind of respiratory disease. My own study looked at the value, or found that the value that our professions place on education and our teaching and learning skills is far less than it does on our clinical skills. And yet, as practitioners, our whole philosophy of education and self-management is underpinned by engagement and education and teaching skills. Taking account of patient values and preferences. So one of my colleagues from AUT, Julie, is undertaking as part of her doctoral study what really matters to the youth of youth living with bronchiectasis. And I think that would be really insightful as to what matters to them, because believe me, doing their physio really doesn't. We're so down that food chain. And I don't think, and I haven't focused on this because there's colleagues talking tomorrow about the wraparound services that we can offer people with different cultural considerations. But perhaps what's useful is exploring what are the cultural attitudes. In certain cultures, the attitude about having a lung disease is a gift. It has been given to them, and they will have to work, and they are accepting of it. So to try and rehabilitate, to try and get people to be proactive about that lung condition can be quite challenging when you're up against a philosophy which is one of acceptance. It's this constant pull and tension between the ideal management and realistic management. For me, if they do something, that's better than nothing. And yes, I would love for them to do physio twice a day, and but the reality might not be that. So I would better engage somebody so I can work with them until they can make that happen into their day, or until that priority, their health priority, comes up the priority scale. There's a challenge between those bigger system measures that we need to capture and actually engaging people, looking at their goals, looking at the ICF model of activity and participation. How can we get people to function better in the community? So there's the challenge between the self-management and engagement. And I'm not here to talk to you about self-management per se, because it's very, very well documented. But what I would do is challenge how we start thinking about it and thinking about it differently. So again, looking at that sedentary space, so Harry's work again was a meta-analysis. I appreciate it's really busy, but if you just focus on the slides about starting to work on changing people's attitudes, changing the social support to facilitate the time or the space so that mum or bro can go and do their physio, go and take their tablets, go and exercise. Creating habits. When we were much younger, brushing our teeth, doing our hair was a habit that was painful for our parents until it became automatic. Can we help to facilitate habit formation, where things become a part of a natural routine? From this slide, just flagging up again, but some AUT colleagues, fairly recent. Again, what was interesting when they did a meta-synthesis of a number of studies, they found that actually clinicians still had this thing about controlling patients and controlling their behavior. And yet, when they moved into that area of, okay, can I ask what matters to you? Actually, it was quite transformational, and there was better engagement. But there are challenges, and there will continue to be, which are challenges related to the timing of our appointments. We're still in this very fixed system, and maybe we need to be a lot more flexible. I think part of our success, and I include my colleague Nicola in this, and also our Conroy and Wendy as physicians, our youth clinic, even we're surprised at how it works, because we've had over 95% of young people. So we do a clinic once every two months now. It's overbooked, so it's about 22, 23 people. Believe me, the glass of wine tastes so sweet at the end of that day, because the amount of people we get, whatever responses, but essentially they turn up. But what we have done is invest so much time in preparing the clinic to say, they'll rock up, don't worry, it doesn't have to be 9:05, you don't need to phone them, and 3 phone calls and then they're DNA'd. Yeah? So it's about working with the whole system to make it user-friendly. So our attendance, interestingly, on the last one was we got a sense that people wanted it outside of school time. And in fact, that was our highest UTA and DNA rate compared to when we finally had it on a Friday, where people could self-select ideally what time they would like to come at. So again, if we can get that attendance from a very challenging group of people, they're turning up. They might not all be doing physio the way I would ideally like it to be, but they're doing something. So how do we connect with communities? I just really wanted to flag up, this is rather than put up all the agencies we might be involved with, this is actually somebody, it's not his photograph, thank goodness for Google Images. So this is a gentleman that I worked with who was about 23 when he was referred. Marked bronchiectasis, so FEV1 of 38%, obesity and OSA. When he first came to see in clinic or attend the clinic, he was wearing one of those beautiful gold standard bracelets from the probation office. So we had to liaise with the corrections facility to allow him the time and the space to be able to at least attend the appointments. So he was working at the time. He since has given up that job. We're now working in terms of looking at other education providers and opportunities. He is significantly overweight, but telling an overweight person to exercise and it's good for your health won't work. So again, navigating through those barriers, working with a charity, so we were able to get him a gym membership and I could design a program for him, which was actually so successful that we've now got wins actually paying for his gym membership. And yes, he's still overweight, but he's less overweight than he was when I first saw him. Again, working with the scheduling staff of our appointments so that he can come to the appointments at a timing that works with the free bus, because finances are an issue. So again, it's just showing you how sometimes you've got to clear the way to make things happen. And it doesn't have to be a physio, it should and could be all of us. While I appreciate this is kind of one end of the spectrum of people with health literacy and access to smartphone, I can guarantee that most of those young people, and in fact, most people now will have a smartphone, they mightn't know how to use them other than just dialing and phoning people, but essentially, how can we connect them with some of those electronic resources? And I'd flag up the Bronchiectasis toolkit as an invaluable, not just valuable, but invaluable toolkit, designed by a physio based in Australia, some really good videos, so appealing to the visual learners, very informative. So again, it's raised some highlights from the Bronchiectasis conferences, both 1 and 2, that Caroline was there. And again, really good resources. Bronchiectasis Foundation, based up north. We've got services and again, lovely resources from a number of other agencies. It's just about tapping into the one that works best. Even though our DHBs haven't kept up with technology in terms of our rather prehistoric phones, but most people, and particularly with youth, we communicate with by text. So nowadays, the barriers can include, oh, I didn't get my letter, but you kind of think, but you're on dial hog, and you would have got the text. And in fact, you would have got the text followed by the next attempt, followed by the report that goes back to the clinic that says they couldn't get in touch with you, so then you had the call centre try and call you on the very number that we've got. But again, we're not in the priority group. When you move home, when you change your phones, which young people do, they're not going to always update us until they come to a hospital or come to the clinic. Again, using the technology to map my walk, can we use nowadays very, very accessible pedometers, be it electronic or old-fashioned. But I would suggest that this is one end of that educational spectrum. The other end is the humility when people say, so where are my lungs? And you forget that people have no concept of where their lungs are, let alone where's all this phlegm coming from? So again, using simple pictures. So I have a children's book with lungs, and it shows some of the tracheobronchial tree, and it shows the different segments. So again, I can link the CT findings with this very, very simple children's book picture. And then, yes, we can upgrade it depending on the technology available. But there's some interesting things happening. So again, working with a Northern Ireland group, they're developing an online action plan for people with bronchiectasis. Hasn't been launched yet, but again, presented at the last conference. This is just a flavour of some of the research that I'm involved with, either directly or indirectly. Again, looking at the subcultures of people that come to the clinic or don't come to the clinic, looking at, for example, building on Sandra Bassett's original questionnaire survey, looking at what are the tongue and health beliefs about illness that might impact on their attendance or their aspects about, or their attitudes to do with bronchiectasis. I'm going back to Dublin for over Christmas, and again aiming to go up to University of Ulster to meet up with the colleagues who are launching this app. The app, interestingly, they trialled it. The average age was 57. I think in our population in New Zealand, we can bring that down a decade or two, so we'll work with that. And then the new quality of life questionnaire specific to bronchiectasis, looking at things like not just physical and social and emotional functioning, but looking at the treatment burden, the symptoms as well. What's interesting is it's already been translated into 29 languages. Apart from English and some Asian languages, it would be really good that we worked together in translations that are applicable to our populations, and maybe making it online or as a survey monkey kind of thing, rather than just a paper-based. But I think looking at whether it's sensitive enough to our populations, I think it'll be a long while before we can compare it to some of the established, like the St. George's or the chronic cough questionnaire, but at least now it's within that pure bronchiectasis space. So just kind of drawing to a close, I think it's important that we look at multiple touch points, both in terms of the age of people that we work with, the trajectory of their disease. And again, when I work with students and say, well, this person is 15 and they've got severe lung disease, in their mind, they're thinking COPD and age 70. So again, it's shifting that kind of awareness that chronic lung disease can be across the age spectrum. And we need to be responsive to that. And maybe we need to reinvest time to revisit people. And this, again, might be where the register will have a good utility in allowing us to draw people back for maybe a warrant of fitness. I think we do need to get that longitudinal data. We're very focused on the here and the now, which is brilliant, but I think the here and the now and the forever and the future are actually really important. So if we're looking at the investing in the community, we need to have those long-term commitments to improve the long-term health benefits, because there are families living in houses that are exposed to all the preceptors that might instigate bronchiectasis. So are we looking at mum, dad? Are we looking at 6 children who might ultimately end up with bronchiectasis? So just to conclude, I think it's really important to utilize your physiotherapy colleagues. I think drawing on education is something that we all need to improve on, in terms of looking at how do we engage people. Do we appreciate that they might be visual learners? Do we appreciate that they might be kinesthetic learners? We've got downstairs, having just had a few minutes to float around, grab hold of those samples so you can demonstrate. Let people play with them and see how they put things together. Do people have the dexterity to handle some of the capsules, or do you need to think about a different device? Think differently. It's not just about the medicine, it's about the device and the utility. I think also somewhere that we need to grow a lot more into is the advanced care planning state. And I think we're not necessarily as good as we should be, but knowing that the end cometh to us all, can we allow people to die with dignity? Can we have these conversations early? As shocking as they might be, young people do pass away, as we all will. So can we have this open conversation so it's not a last minute when people are acutely unwell? I think what my patients, they laugh when I mention it, but actually I coined the phrase from them: can I come back from my annual warrant of fitness? Can I come back and have a bit of a check to see where am I and where should I be and how bad am I compared to other people? People want that, where am I on this scale? And I think really just to flag up that it's a long-term investment. It's not just that one clinic visit, it's actually multiple clinic visits, and it's over that trajectory of time, which we all need to commit to, both in terms of time, resources, and as Conroy said, research. Thank you.